Assessment for umbilical cord prolapse. One, assess the woman to be transferred to the nearest consultant unit or hospital for delivery. And the second one is assess the client's ability to follow instruction. Gather all items you will need for internal examination and prepare for double setup. Good day, ma'am. I will demonstrate the emergency management for prolapse of the umbilical cord. First, I will gather all items that I need for this procedure. For rationale, for easy accessibility for the inspection of the external genitalia, vagina, and the cervix. Next is identify the client and introduce yourself and explain the procedure. Good morning, ma'am. Ma'am, can I check or see your wristband? Okay. Ma'am, I'm Ricardo Bautista Jr. I will be your nurse for today and I will do internal examination to assess the progress of your labor. For rationale, to obtain client's cooperation and work simultaneously. Position the client on the examination table and three positions are employed for internal examination, which are the dorsal recumbent, Sims position, and knee chest position. The knee chest position, the Sims position, and the dorsal recumbent position. Ma'am, you will be positioned on the examination table to check for the progress of your labor. The aforementioned positions are made best so as to expose the gynecologic area to be examined. Positions depends on client's capability and examiner's preferred position. Drape the client and expose only the gynecological area. Ma'am, I will put the drape on you and will expose the part that I only need to assess. The rationale, always respect the client's modesty and to provide privacy. Next is wash hands and put on examination gloves. Ma'am, I will do hand washing, then I will put on examination gloves for the internal examination and I will change into the sterile gloves after I assess your progress of labor. Rationale, to protect the healthcare provider from contracting gynecological diseases caused by highly ineffective organisms. Assess the well-being of pregnant woman if the cord is visible outside of the vagina or can be felt in the vagina below the presenting part and handle the cord carefully. Do not pinch the cord. Ma'am, while I insert my two fingers, kindly take a breath while I do the internal examination. If I see a cord protruding on the vagina, I will handle it carefully. The rationale, on inspection, the cord may be visible at the vulva and to assess the cord for pulsation. After performing the internal examination, next is assess the well-being of the fetus and check or monitor the fetal heart rate. Ma'am, I will now assessing the heart rate of your baby by putting my stethoscope on your abdomen. The rationale, cord prolapse is first discovered only after the membranes have ruptured. When the fetal heart rate is discovered to be unusually slow or a variable deceleration fetal heart rate pattern suddenly becomes apparent on a fetal monitor. To rule out cord prolapse, always assess fetal heart sounds immediately after rupture of the membranes, whether this occurs spontaneously or by amniotomy. If you are in Simong facility, report the findings to obstetrician for emergency cesarean section. And if you are in Bimong facility, the following procedures below are the emergency for prolapse umbilical cord. Next is assist the mother to do knee chest position, head tilt, and left lateral position. Instruct the mother to take breath and control urge to bear down. Ma'am, I will assist you in a knee chest position. Take a deep breath and do not bear down if you have the urge to do so. Rationale. Knee chest position and uses gravity to shift the fetus out of the pelvis. Elevate the presenting part by feeding the urinary bladder by inserting a catheter. Instruct the client not to bear down. Ma'am, I will be inserting a catheter that will inflate your bladder by a sterile fluid to help in reducing the compression and the prolapse cord. If the decision to deliver interval is likely to be prolonged, particularly if it involves ambulance transfer, elevation through bladder filling may be more practical. Bladder filling can be achieved quickly by inserting the cut end of intravenous giving set into a Foley's catheter. The catheter should be clamped once 500 to 750 ml have been instilled. It is essential to empty the bladder again just before any delivery attempt, be it vaginal or cesarean section. Elevate the presenting part by inserting your two fingers in the vagina and push the head of the fetus upward. And do not remove your fingers until you arrive at the operating room or by instruction of the obstetrician. Ma'am, I will put my glove hands into your vagina to push the head of your baby upward and take a deep breath when you have the urge to bear down. Of the presenting part is thought to relieve pressure on the umbilical cord and prevent mechanical vascular occlusion. And to prevent vasospasm, there should be minimal handling of loops of cord lying outside the vagina. Call out the time of birth and gender of the baby. 9:30 p.m. baby boy. Rationale, to safeguard mother and baby against infection and to facilitate spontaneous breathing of the infant. If the newborn is with good cry, I will proceed with EINC. If it is not crying, I will cut the cord and resuscitate the infant if needed. Next procedures is remove gloves and wash hands. The rationale for infection control. After procedure, I will document the date, time, and the procedure. The rationale to provide accurate data in the care of the client.